about the anterior chamber IOLs. I was amazed and surprised what to do because I have not done anterior chamber IOLs for the last so many years. And then I was asked, are you going to talk or I will be passing it on to somebody else? I said, I'll go and talk. Frankly speaking, I did not know anything about anterior chamber IOLs till I was asked to talk about, and then I started exploring this field, and the story started building in a very interesting way. The purpose of this presentation is to share the same story with you, and it has really led a different experience for me. The basic criticism with anterior chamber IOL is that it is implanted on a platform which itself is not stabilized. That is iris which is moving, it's causing iris chafing. The haptics are put on a vital structure which is an angle which causes glaucoma and hyphema, and proximity to endothelium causes chronic endothelial loss. The other issues are non-physiological placement, uveitis, glaucoma, hyphema, astigmatism because of larger incision, acute and chronic endothelial loss, cystoid macular edema, and pupillary distortion in putting the anterior chamber lenses. But what we do not understand is that whatever citations we have gone through, the lenses have been put in an emergency situation, like the other doctor was saying, the lens is dislocated, the surgeon is not prepared. The inventory may not be there, and the surgeon did not get a chance to do a proper preparation. So most of our previous citations, those of you who are interested to go through, there's an interesting article by Dr. N.S.D. Raju and it's available on Google to get an idea of his time in his version about the anterior chamber IOLs. So most of our previous citations are based on older makes with relatively poor finish, and then were our microsurgical skills less developed and less advanced. We did not have that good OBDs. But now we have tumble polished, better finished IOLs. When I talk of tumble polish, you may laugh. Why do you mention it? Single piece, high quality PMMA with flexible and open haptics. They're more standardized sizes, good microscope, vitrectomy support, improved vaulted design. And this has changed the whole perspective and opened doors for review. And then I came to know that the anterior chamber lens, the most standard thing is what we call as Kelman multiflex IOL. This is what it looks like. And then I went to the Aurolab site, and I don't have any commercial interest to know about it. And 3 sizes are available. They are of 12 millimeter, 12.5 millimeter, and 13 millimeter. So these sizes are important in case if you are planning to do an anterior chamber IOL. Interestingly, another design is available, which is quite interesting, and it's a very different shape. I have never put it, so I do not know much about it, but sounds very interesting. So when I was exploring this story, another chapter opened, and I went into an altogether different area, which is known as phakic IOLs. When we went into the world of phakic IOLs, there were 3 places where you could put the lens. You can put it either in the pupillary plane, or in the sulcus, or in the anterior chamber. And surprisingly, anterior chamber looked like a more favorable destination for phakic IOLs. In the JCRS review of 2003, the phakic IOLs they have mentioned are these 6. And the lower 3, I'll go because this cursor is not moving, so I'll just go and show you that these are the 3 lenses which are out of the 6. These are the 3 lenses which are to be put in anterior chamber. And they are made of, the other one is made of silicone, and these 2 are PMMA, and this is heparin modified PMMA, and the phakic 6.2 on your corner down is exactly what the Kelman multiflex look like. We do know anterior chamber better than our ancestors. We have better tools to deal with. We have UBM is anti-chamber OCT is pentacam, and we can measure the volume, angle, internal diameter, and effective lens position now. These are the photographs which show the OCT picture on the top right, the UBM picture on this side, and the pentacam image. And the two red arrows here are showing the correlation of white to white with the anterior chamber angle. And the point which is interesting is that the relation of white to white with the anterior chamber angle would vary from patient to patient. The advantage of anterior chamber IOL is that it is easy to insert. Thank you very much. It is easy to insert. There is no special training required, no tumbling, no two-hand techniques, very simple. Everybody knows how to put it. It's very less time taking, and no special equipment is required. This last word has to be taken with a finger crossed. The two things which we have to take care is white to white diameter, and the classical description is that you add 1 millimeter to the IOL size, and you use simple SRK2 formula. Now, when we say white to white plus 1, this is entirely not dependable, and what I did, I simply measured the white to white of my 12 patients, and it varied from 10.8 millimeter to 12.3 millimeter. So that means the patients which we are likely to see will have a larger white to white or a smaller white to white. So large variability will be there, and that's why the three sizes which we are currently having may be required to have some more. What we need is a meotic pupil, an empty chamber. That means if the vitreous is there, just do vitrectomy, and a peripheral iridectomy. Another interesting topic, another interesting chapter opened into the same novel. Now we were writing a story, it has become a novel now. And I came across a lens which is made of acrylic, and that's a foldable IOL. It's made by Acrytech of Germany, which goes through an incision of 2.8 to 3 millimeter, and which can be put into the anterior chamber with a small incision in a foldable metal. And that's how your anterior chamber lens looks like. It's very different than what our previous photographs showed in our initial slides. So there is a room to think about it, and newer possibilities and newer things might be taking place. They are unfolding into it. In the JCRS review of 2012, the visual outcomes and prevalence of long-term complications of in-the-bag implantation and secondary implantations were comparable, and they said that posterior chamber IOLs have higher complications because of the PCO, which we don't have anyway in the anterior chamber lenses because there's no capsule. Another study of 2003, which is a better study of 20 aphakic eyes, have classified anterior chamber IOLs as safe option, although they said that a larger period of follow-up is required because of the possibility of development of glaucoma and chronic endothelial loss. The contraindications are shallow anterior chamber, unhealthy corneas. They say it is 1,000, and I would say less than 1,500 we should think about putting it. Peripheral anterior synechiae, more than 2 clock hours, history of glaucoma, history of associated procedures like trabeculectomy. As a cataract surgeon, we should know about all the things like scleral fixation, pupillary fixation, and we should also know about anterior chamber IOLs so that we can give a picture like this. The take-home messages: people lost interest in AC IOLs in the early 90s. There has been significant improvement in the IOL design because of the open loop and material. Our understanding of the anterior chamber has changed. As phakic IOLs, anterior chamber seems to be a very preferred destination. Long-term favorable safety results are available in carefully planned surgeries. It is easy to perform surgery and doesn't require special training or equipment. Follow-up is desirable for longer period post-operatively. Thank you very much for the patient listening. And this is also an interesting photograph of eye doctors wearing glasses, which may be of importance or interest. Thank you very much.